Hello, everyone, and welcome to the Radiology Cardiothoracic Imaging podcast. My name is Sonia Barra, and I'm the editor-in-chief of the journal Radiology Cardiothoracic Imaging. The host of our podcast is Praveen Ranganath from Dallas, Texas.
Hey, Dr. Ibarra. Hello, everyone.
Hi, Praveen. In this series of podcasts, we will break down recent articles and trending topics from the journal through conversations with the authors, the editors, and experts in the field. For all of you out there interested in cardiothoracic imaging, subscribe and listen to the podcast to keep up to date with recent developments in cardiothoracic imaging.
Hello, listeners, and welcome back to the Radiology Cardiothoracic Imaging Journal podcast. I am your host, Praveen Ranganath. On today's episode, we will discuss a very interesting original science paper recently published in the journal. The paper is titled Cardiac Imaging Trends from 2010 to 2019 in the Medicare Population. This paper comes to us from our colleagues at Thomas Jefferson University in Philadelphia. The lead author is Dr. Russell Reeves, and the senior authors are Dr. Ethan Halpern and Dr. Vijay Rao. I had the pleasure of speaking with the lead author, Dr. Reeves, on this episode. But before we dive into that paper, let's do a brief overview of this publication. The authors sought to answer the following question: how has cardiac imaging utilization in the United States changed in the last decade? Certainly, many of us in the cardiac imaging community have anecdotally seen a revolution in cardiac imaging over the last decade. This paper offers an objective perspective on the overall landscape of cardiac imaging trends. The authors utilized the large Medicare database of physician supplier procedure summary files to procure data for their analysis. They focused on the years between 2010 and 2019. This database is massive, including data for each cardiac imaging study performed on the millions of Medicare beneficiaries in the United States. Most importantly, there are data regarding exam type, practitioner type, and exam location. And it was in these categories, once again, that's exam type, practitioner type, and exam location, that the authors investigated trends over the last decade. Exam types included transthoracic echocardiography, stress echo, transesophageal echo, coronary CTA, stress nuclear myocardial perfusion imaging, cardiac PET, and cardiac MRI. Practitioner types included cardiologists, radiologists, and non-cardiology, non-radiology providers. And lastly, the location types included physician outpatient offices, hospital outpatient departments, emergency departments, and inpatient settings. All right, that's enough background. Let's touch on a few of the interesting highlights that I noticed in this publication. Echo use reduced in cardiologist outpatient offices and increased in hospital outpatient departments. Echo use in the ED increased by both cardiologists and non-cardiology providers. Just like echoes, cardiologist-performed coronary CTAs shifted from the cardiologist outpatient offices to the hospital outpatient departments. By contrast, radiologist-performed coronary CTAs increased in all settings, outpatient, inpatient, and in the ED. Stress nuke scans dramatically reduced in the office and inpatient settings over this time period. MPIs did increase in the hospital outpatient department, but to a lesser degree than that decrease. Cardiologists performed cardiac PETs dramatically increased in the office setting, while radiologists performed cardiac PETs remained relatively stagnant. Despite declines in stress nuclear MPIs and increases in coronary CTA and cardiac PET, stress nuke scans continued to dominate the absolute number of scans throughout the decade studied. Cardiac MRI numbers by all practitioners slightly increased in the hospital outpatient department, but overall numbers remained low. Okay, so there is a whole lot of interesting stuff to unpack here. Did these trends match with your anecdotal take on recent cardiac imaging trends? What do we hypothesize is driving these trends? Where will cardiac imaging trends go in the future? To help answer these questions and more, let's now jump into my conversation with Dr. Russell Reeves, our featured paper's lead author. All right. Welcome back, listeners. I am pleased to have with us the lead author of our featured paper, Dr. Russell Reeves from Thomas Jefferson University. Russell, thank you so much for joining us here on the podcast to discuss your recent publication in the journal.
Thanks for having me. Glad to be here.
Of course. So, Russell, let's start by learning a little bit about yourself. Where did you train? Where are you currently? And what are your academic areas of interest?
Sure. So born and raised in Pennsylvania. Went to undergrad at Hopkins, then to Dartmouth for med school. After that, now I'm at Thomas Jefferson. I'm a third-year radiology resident. And my areas of interest right now are really healthcare utilization. We have a strong department within the Department of Radiology that does research on imaging utilization. We've done it for maybe 20 years now. And so I'm just continuing on the legacy.
Excellent. Well, glad to have you in the cardiothoracic imaging community. Before we dive into the publication itself, let's talk a little bit about the landscape of cardiac imaging before that 2010 to 2019 timeframe that's encompassed in your paper. Could you give us just a brief lay of the land as to what cardiac imaging looked like just immediately before 2010 in terms of what the most common imaging studies were, who was practicing those imaging studies, et cetera?
Sure. So prior to 2010, there was actually a large boom in utilization of non-invasive cardiac imaging. So as the technology got cheaper, MRI, CT, ultrasound, it became more feasible for clinicians to be able to do those studies in their offices. Being the imaging heavy clinicians that they are, cardiologists were quick adopters to a lot of these technologies. So prior to 2010, we saw immense growth in the office of echo especially, but also myocardial perfusion imaging with SPECT and SPECT-CT. And then coronary CTA and cardiac MRI grew to a lesser degree, but there was pretty much booming growth. Now, prior to 2010, there was two major changes. So there was the Deficit Reduction Act of 2005, which basically cut reimbursements to those office-based imagers. Then the second double whammy of a hit was code bundling for echo in 2009, making it so that you really weren't getting reimbursed as highly for complicated studies as you were before. So it became a big disincentive. So prior to 2010, we saw the peak and the curve of the line essentially returning back down to normal or pre-2000 levels.
Got you. Okay. You had mentioned a couple of pretty important acts that were passed right around that time, just before 2010. I have to admit, as a cardiac imager, and I'm sure there are a lot of us out there that don't really have a good command of billing and coding. It's sort of a black box to a lot of imagers, actually a lot of physicians in the country. We also have a good deal of international listeners too that may not have as much familiarity with the US payment system. Could you just give us a brief overview of what cardiac imaging coding and billing and reimbursement looks like?
Sure, absolutely. So it is very complicated, and I definitely don't claim to know everything about it. But the couple things I think people need to understand are when in the United States, when you do an imaging study, the first thing that happens is a coder will assign that study a specific code, and that helps researchers like me identify it. So if you get a cardiac MRI, it's one code. If you get a CTA, it's another code, et cetera, et cetera. And based on that code, you get a certain level of reimbursement. Now, prior to processing that claim, there are different modifiers that can be added to the code that'll either reduce the reimbursement. So let's say it was a non-diagnostic study, or might increase the reimbursement. So maybe if it was performed at a higher cost center, so it's costs more to perform imaging in the ED or in the hospital than it does in a private office. So those are the major components. And then the other last thing I wanted to mention is in each bill, you can either bill for the professional components, meaning what I believe is going on in the study, what I personally think the diagnosis might be, or you could bill for the use of the equipment. So just having the CT scanner and having someone get a scan, you could get paid for that, but not necessarily interpret those images. So it is very complicated, but luckily with these data, we can parse out all those details and get quite a bit of information.
Okay, with regards to those data themselves, what exactly are we looking at? Is this Medicare data? When was the Medicare data from? And what types of studies were you including in your analysis?
Sure. So for this particular paper, it's all Medicare data. It's called the PSPS files, the physician, supplier, et cetera files. I can't remember the acronym off the top of my head. But basically, using this data, we can understand all Medicare beneficiaries that are Medicare Part A recipients. There is something called Medicare Part B, for those who are not aware, which is sort of a private insurance that patients can get over the age of 65. Those patients are not covered. So all in all, we look at 2010 to 2019, there's about 40 million Medicare beneficiaries on any given year, 37 to 40 million. So it rounds out to be quite a large population when you really think about it. So it's an impressive data set. We can learn a lot from it, and we can really know what the trends are, at least in that Medicare greater than 65 population.
So for those studies that are included in that enormous data set, are you able to figure out who the provider was or what type of provider was that was doing the billing? Are you also able to figure out where the location of the study was?
Right. So every time, the quick answer is yes. The long answer is every time one of these studies is billed, the specialty of the provider is assigned to that particular bill. So if I'm a cardiologist, a certain code is linked with that. If I'm a radiologist, a different code. If I'm a urologist, another code, et cetera, et cetera. And then for place of service, there are also specific place of service modifiers that Medicare procures that you can add to the same bill. And like I said before, it's important to specify that for billing purposes, because in the ED, it's more expensive to do a study than it is in an outpatient imaging center.
Gotcha. Okay. To review, what were the 4 primary imaging locations that were included in your analysis, just so that we have a framework for talking about where the trends are going forward?
Right. So the main imaging locations in the United States are inpatients, outpatients that are in a hospital outpatient department. So HOPD, we abbreviated in the manuscript, in the emergency department, and then also private physician offices. There are smaller locations of service that these things do get performed, but it's relatively low. So like subacute rehab facilities, et cetera. But most of those places aren't, billing for coronary CTAs, for example.
I imagine the overhead to have a scanner in a small office might be a little tough, in addition to the actual geography. But no, that makes sense, and that's very helpful for talking about what the next part of the conversation I want to move to is actually following some of those trends from 2010 to 2019 in each of those modalities. So you've done a great job of separating out how each modality changed over time, both based on provider type and based on location. Because that's a lot to handle all at once, let's do it modality by modality. So why don't we start with echocardiography? On the whole, what do you think some take-home points would be for how echocardiography use has changed over that time period that you analyzed?
So echocardiography, it's a really interesting topic because we actually had 3 different types of echo that we looked at. We had regular transthoracic echo, we had stress echo, and then we had transesophageal. The transesophageal really acted as an internal control because you would think there aren't many new indications for transesophageal echo, so that should be pretty much flatline across all of the years, which is what we saw. Where it gets really interesting is the transthoracic echo, particularly in patient offices. So what we saw was in cardiologist offices from 2010 to 2019, there's really about a half, 50% reduction in the number of echocardiography that was being performed there. And in the hospital outpatient departments, there was a growth of about double by cardiologists. So it was really a shift 1-to-1, cardiology from in the offices to cardiology and hospital outpatient departments. For the other, imagers, radiologists, we really don't perform many echoes, so about less than 1% pretty much in every setting.
Let me ask you something about that shift from outpatient to hospital outpatient. So to clarify, it sounds like office-based echocardiography reduced while hospital outpatient-based echocardiography increased. If that's correct, why do you hypothesize that shift happened?
So it's a really interesting shift. And those of us who were in practice during that 2007 to 2012 period might remember there was a lot of restructuring, not only in cardiology, but also elsewhere in medicine, where many private practice groups either became absorbed by big hospitals or strategically aligned with them. A lot of them either sold their imaging equipment to hospitals and maybe made deals to do a certain number of echoes in the hospital outpatient departments, et cetera. So that's really the change, is rather than having a private practice dominated medical society with cardiology respect, there was more alignment with hospitals and shifting to hospital outpatient departments.
Okay, interesting. And with regards to the emergency department side, even anecdotally, I have seen a tremendous increase in emergency department echocardiography use. One thing that you note that's pretty fascinating in your paper is the increasing use of ED echo by non-cardiology practitioners, which I presume are primarily ER physicians. Is that related a lot to point of care ultrasound, or are there other trends underneath this that may explain that increase in utilization of ED echo?
No, I think you really hit the nail on the head. So in the ED, we didn't stratify it in the paper, but most of those other providers were emergency physicians. So presumably all point of care ultrasound. Now, unfortunately, these data, you can't get granular information to know whether it was point of care or whether maybe there was a tech that did the ultrasound and the ED provider billed for it. You can't get that kind of information based on the study. But they were ED providers that billed it. The thing that I think is really interesting is we saw growth not only by cardiologists, a small growth in the emergency department, but also by these non-physician, non-cardiologist, non-radiologist providers. And you would think that, okay, if the ED physicians were doing more transthoracic echocardiography, maybe there would actually be less cardiology transthoracic echocardiography because they don't need it. Maybe the ED physician found that the heart was normal and didn't need the cardiology consult. But really what we're seeing is growth of both. So that means that maybe it's not adding quality to care. It's really uncertain. And actually there was a recent publication. I forget where it came out, but just this week I was thinking about this exact question and I saw that pop up in my email. So interesting stuff.
So is the implication that there's some redundancy of some of the care that's being received by maybe more than just ED patients, but for this example, ED patients receiving echocardiography?
Yes, exactly. So one would think that if you were an ED provider and you used point of care ultrasound, you may, in theory, be able to decrease the amount that a cardiologist would have to do. You would obviate a consult if it was unnecessary. So now we're seeing duplication of efforts. So it makes it, a curiosity of whether this is adding value to the patient's care, whether it's just duplicating billing, whether it's just looking for trouble when none was suspected, all of these things. It's really an interesting quandary.
All right, very interesting indeed. Let's move to another modality. Let's talk about coronary CTA. So what are some big takeaway points in that 2010 to 2019 time period for coronary CTA changes? I can already predict it probably increased a lot, but want to hear it from you.
Sure. So coronary CTA did increase quite a bit in all sites of service, really. So in cardiology in particular, pretty much half of it fell in the office. The rates fell by half, and then it doubled in the hospital outpatient department. So that was probably a one-to-one shift. Again, same thing with the echoes. Cardiologists being more aligned with hospitals, less private practice groups, and just shifting their services to the hospital outpatient departments. On the other hand, radiologists, they really saw a lot of growth. In 2017, radiologists actually overtook cardiologists in the greater number of coronary CTAs in the office setting, and then also grew in the HOPD, the outpatient departments, and also inpatients. So really, it's a booming area for radiologists to add value.
Very interesting. I presume that has to do at least in part with the cost of the equipment overhead and maintenance, as well as the technologists that are performing it. Some rather expensive on multiple fronts, more than just financially, to sustain a coronary CT scanner, more just a CT scanner in general. Do you predict that that explains maybe some of the reason why radiology has increased its coronary CTA use more than, say, our cardiology colleagues?
Oh, absolutely. It's incredibly expensive to own and maintain your own CT scanner, especially if you're not using it enough. So for a small cardiology practice to own one and maintain it and to actually make any kind of profit off of it, I think is very, very, very difficult. I mean, there's other things too. So cardiologists, they're obviously experts of the heart, look at it all day, every day, but they're not necessarily the expert of the lungs. And I think with radiologists, since we're looking at all these different imaging modalities and organ systems, we're much more comfortable if we find incidentals, if there's a solitary lung nodule, for example, and what to do with it. So I think there's lots of reasons that explain that, but I think it's a great opportunity for radiologists to really reassert a foothold in cardiac imaging.
Okay, very interesting. We kind of mentioned coronary CTA as the primary thing. I know that cardiac CT in general is probably the more appropriate terminology, but with regards to coronary CT imaging, a interesting corollary would be myocardial perfusion imaging from the nuclear side. So let's talk about that. How did myocardial perfusion imaging, specifically SPECT and SPECT-CT imaging, change over that 2010 to 2019 period?
Right. So, I mean, there was really immense declines by myocardial perfusion imaging, mostly by cardiologists in private offices. I mean, there was immense utilization prior to 2010. And after 2010, the rates really dropped by about 80%. And the thing that's really interesting is when you looked at the hospital outpatient departments, the amount of growth was not that, great. It wasn't much of a shift. So you'd think if every single one of these studies was indicated, absolutely necessary, patient's, life or death or some other major decision, you would have to get it. You'd have to get it one way or another, whether it was in an office or at hospital outpatient department. And the fact that you don't see a one-to-one shift really suggests that maybe a lot of those weren't necessary after all.
Okay, interesting. So that's a location-based shift. If I can compare MPI with coronary CTA, did the rate of decline of MPI match the rate of increase in coronary CTA for all practitioners?
So I would say in terms of a percentage basis, that might be the case. But when you look at the absolute rates, they're way different. So, I mean, we're talking about tens of thousands of myocardial perfusion imaging studies versus a couple thousand, really, coronary CTAs. So, and that's where percentages can sometimes mislead people. And if you read the paper, you'll see that I show a percentage and then the absolute rates every time because it never shows the whole story. But yeah, that's a good point.
Okay, interesting. So even today, myocardial perfusion imaging, SPECT and SPECT-CT, dominate the world of, let's say, coronary and myocardial imaging relative to coronary CTA.
And it's interesting because, they do tell you different things, right? So coronary CTAs show you the anatomy and it shows the area of stenosis, and myocardial perfusion imaging shows you perfusion, right? Similar to PET. And there are kind of different questions you're asking. So I think, I get this question a lot. Well, which is better? Which one should we be using? Some people say coronary CTA. Some people say the more physiologically appropriate imaging would be myocardial perfusion imaging. I think it's a nuanced question, but I do think that at least some of the recent data suggests that coronary CTAs are quite good and probably should be the modality of choice for a lot of these patients.
Yeah, a lot of our European listeners will agree with exactly that, particularly given the changes in the UK. You mentioned cardiac PET. So a lot of people probably aren't too familiar with cardiac PET amongst our listenership, save for a few pretty large academic institutions. With regards to changes in cardiac PET, I presume it's only increased, but I'm curious to hear how it's increased from you.
So cardiac PET is definitely increased. I don't remember the numbers off the top of my head, but I think there was close to a tripling by cardiologists in private offices. And really that's where the growth was. And presumably it's many of these cardiologists are converting their myocardial perfusion SPECT imaging equipment to PET because they're really very, very similar. there are advantages to cardiac PET that myocardial perfusion imaging don't have, maybe better spatial resolution, et cetera. But presumably that's what's happening, because you don't see much of a hospital outpatient department growth. You don't see much of an inpatient or an ED growth.
That's interesting. And if I recall correctly, cardiac PET was the only imaging modality of those you included in the analysis that increased in terms of its use in the office. All others decreased in terms of office use.
Correct. And, one could think of many reasons why that's the case. It is interesting that it's an outlier, definitely. And maybe one reason could be the technical familiarity. If you had a perfusion imaging equipment before, upgrading to a PET really isn't all that different. So it'd be easy if you're a non-radiologist. It's easy to get rubidium. It's made in a generator rather than thallium, which is made in the cyclotron. There's financial considerations too. The Center for Medicare and Medicaid Services has set their sight on reducing PET reimbursements pretty much every year for the last 5 years or so. And they keep pushing the deadline back. And so it's one of the last outpatient imaging modalities that's still very highly reimbursed. So that could also be one other incentive.
From what you know about those reimbursements, we mentioned coronary CT, myocardial perfusion imaging, and PET. Is there anything that you anticipate may change the rates of use or the dominance of one modality over another based on upcoming financial changes?
So I definitely think PET reimbursements are going to change. It's just a matter of time. Now with the pandemic and all, it's difficult to know exactly when that's going to happen. Maybe it won't be for another 10 years, who knows? But as it has happened with pretty much every other outpatient imaging, Medicare will determine what reimbursement is commensurate to the imaging modality and will ultimately cut it, not only to curb overutilization, but also to give the providers what they feel is an appropriate reimbursement. So I think that's probably one thing that's going to change. I think another thing that's going to change is we're going to have a lot more coronary CTAs. We have had slow adoption in the United States. I think radiologists are ready for that. I think the hardest part is probably bridging the gap between radiology and cardiology and developing a strong, essentially referral pattern to make it so that individual practitioners can be doing a substantial number of these, because as it is right now, the numbers are still quite low.
Okay, fair enough. And speaking of low numbers, why don't we round out the modalities with discussing cardiac MRI? I don't mean to bash the modality, but I know that it's relatively infrequent in terms of the number of cardiac MRs relative to the other modalities we just discussed. Did cardiac MR change substantially in terms of its location of use, types of practitioners over that time period?
Really, cardiac MRI hasn't changed a whole lot based on practitioner or site of service. And I think, part of what you're alluding to as well is, cardiac MRI is really looking for different things, right? At least for most of the other modalities that we talked about, we're looking for coronary artery disease, right? Stress echo, coronary CTAs, perfusion imaging, et cetera. And, although MRI has its perks, it's not really the modality of choice for that. And with this Medicare database and patients who are over the age of 65, that is the largest indication for cardiac imaging. So I wonder a little bit if we redid this study with a privately insured population and looked at pediatric cases, younger people, patients with myocarditis, et cetera, if those trends would be different. But at least for the Medicare data, it doesn't look like there's been much of a substantial change.
Perfect. That leads me to what I wanted to discuss next is what the potential limitations of your study was. I think the most important thing for our listeners is to know what types of pathologies and what types of populations may not have been captured in this data set.
Right. So absolutely. It's all young patient pathologies. Like I had mentioned before, myocarditis is a good example. The Medicare database exclusively includes patients that are over the age of 65, and they need to be patients that are covered by Medicare Part A. So there is a substantial number of patients that opt to get Medicare Part B. That's roughly 20 million patients per year. It's not an inconsequential number. So I can't say that this really identifies every single person over the age of 65. When you think about 40 million, it's quite high and it's quite good. But those things you should really keep in mind and view some of these changes with an eye of skepticism.
Fair enough. And for those not from the States, 40 million people is a substantial fraction of the population. The state's population is a little over 300 million or so. So pretty large database. Another question about what you think the future of cardiac imaging is going to look like. This can be your opinion or informed by what we just discussed. Where do you think the trends of cardiac imaging are going to be?
Well, I think the trends are really going to be more towards CT. I think as things like fractional flow reserve are being adopted by more and more practitioners, you're getting a sense of more of what the function is of the heart, not only where the areas of stenosis are. And I think that's really going to supplant a lot of the imaging that was done in the past. I also think that there's going to be more quality metrics associated with imaging. As Medicare had identified in the past, imaging was really, one of the things that was the largest growing and largest expenditure for a long time. So the sights have been set on imaging to reduce reimbursements for a long time. And so tying quality to those studies, I think, is going to be very important for Medicare. And I think it's very important for us all to improve our practice. So other than that, it would be all speculation, but I think coronary CTA is here to stay. I think myocardial perfusion imaging is going to continue to decrease. And I think we're going to see a lot more point of care ultrasound in the future.
Okay, great. Speaking of the future, anything in particular that you and your group are working on at present or are looking forward to?
So we are looking at point of care ultrasound in a privately insured population, looking at rates of utilization, who's doing it, where are they doing it, what are they billing for? That's one thing. Another thing that I think is really interesting is certain health insurances have made stakes in the ground saying that they are not going to reimburse for hospital outpatient departments to do imaging. You have to get things done in a private office. So prior to 2010, we saw a huge growth in private office imaging. Then we had Medicare reimbursement cuts. All that shifted to the hospital outpatient centers. We might see it shift back to the offices. No one knows, but that's something we're working on right now.
Fascinating. All right. Well, any last thoughts before we conclude?
The only thing I think I wanted to say is I think it's very important for us radiologists to be actively engaged in this kind of research, because ultimately this is what's going to dictate what things are viable for a business, for healthcare, for the benefit of our patients. So I'm proud to be part of this team and to do this work. And if anybody's interested, send me an email. I'm happy to collaborate.
All right. Well, thank you very much, Russell. This has been a great conversation. I'm sure extremely valuable to all of our cardiac imagers out there. Thank you so much for coming onto the podcast, giving us your time and expertise.
Thank you. Appreciate it.
Of course. And to our listeners out there, thank you very much for tuning in. If you like what you hear from us from the Radiology Cardiothoracic Imaging podcast, please rate, review, and subscribe to us. We'll see you next time.